And welcome everybody to the 14th session of the HAIO Healthcare Acquired Infections Organization Surge Solutions meeting. Teresa, if you're on the line, go ahead. We'll go ahead and have you introduce us.
Hi, thank you, everybody. As Stan said, it's our 14th meeting. We've been meeting since March 2020. HAIO began in 2013, and we've done several events related to infection control, and we're now moving through the pandemic in various phases and trying to address questions in real time and have collaborative discussions to help everybody work through this. Next. And thank you, everybody. We continuously grow the list of people who have participated and attend these meetings. And
great. This morning, we're going to have some opening remarks from John Downs, who's one of our board members, and also has a lot of experience with a lot of areas right now that are really suffering from the COVID. And then session one is going to speak about facilities operational issues, and session two on planning models going forward. And each session has 5 speakers in that. So John, I believe you're on the phone. If you could go.
Can you hear me, Stan?
Yes, thank you very much, John. Yes.
Excellent, fantastic. So hi, I'm John Downs. I'm a principal with Stroudwater Associates. We're a healthcare consulting firm that does a lot of work with small rural hospitals. There aren't a ton of them here in Massachusetts, but I really wanted to talk a little bit about how COVID looks when we get outside of the larger urban areas and into some of these rural spaces. So back when we were originally struggling with the first wave here in the Northeast, we had a bunch of shortages, right? So we had knowledge. We didn't really know what we were dealing with. Equipment, PPE, ventilators, sanitizers, air scrubbers, all kinds of negative pressure contraptions, things that we were creating on the fly in order to deal with this influx of patients. We had facility challenges, not knowing where we were going to put beds, where could we put more, opening up rehab hospitals as COVID centers, hotels, convention centers. Staffing, we had challenges. Testing, we had challenges. Did we have tests? Did we have enough of them? Therapeutics, vaccines, we didn't have anything about that earlier on. Fast forward, though, and all of those things got better with time. With the mitigation methods that we had, more knowledge, we drove cases lower throughout the entire country, but now we're seeing this other surge, primarily of the Delta variant, but the impact is being felt far less here in Boston, in New York City, in Los Angeles, and substantially more in the Southeast and more generally across rural areas. So I'm not going to go into the reasons why that's happening. Well, you can watch that on the news or whatever flavor you happen to like. But what are we hearing from rural hospitals today that might be different than up here? One, they have enough equipment now. They have enough PPE. They're not reusing masks. They're not sterilizing them with peroxide, any of that kind of stuff. For the most part, there are enough ventilators. The issue in rural communities really is the personnel to manage the substantial numbers of those really ill patients. Those folks get transferred to the big city for care. It's a separate issue when those facilities, like down in Baton Rouge, Our Lady of the Lake, can't take any more patients in there because they're exceeding their capacity. Staffing is a huge issue in rural communities. It's compounded by vaccine hesitancy. In small rural areas, hospitals are having a hard time recruiting not only their clinical staff, but also support staff, and they're really competing with other support industries, service industries, for things like patient care assistants who are jumping between a Walmart and the hospital. So, I was talking to a hospital CEO the other day that said, she can't mandate vaccines because her PCAs or other staff that don't want them will just leave and go someplace else. So, certainly what can we do? I think that once companies begin mandating vaccines, we'll start to see an improvement on the hospital side. But what can we do as a design group continue to design the most staff efficient spaces so they can do more with less. Of course, our core mission, preventing healthcare associated infections, it's also paramount to our work. So any work we can do in improving the design and processes to that end will also help things. Another major issue for small rural hospitals, and one that directly affects design, is identifying opportunities for resilience of use, keeping everything else running when we're dealing with the COVID surge. So, we kind of had to deal with that a little bit in Massachusetts. We shut down elective procedures. We did all kinds of things, but now we've figured out how to deal with that a little bit better. Potentially infectious patients, particularly respiratory related issues, presenting to the hospital, we've had to figure out some workarounds. And in many cases that caused issues, and it still does down south, with having to cancel, suspend other types of scheduled patient care, or even worse, scheduled patients feeling concerned about presenting to the hospital out of fear that they'd be exposed to something. So what can we do? I'd say thinking about separating regular clinic and office practice flow, think about the pediatric offices where there might be sick waiting versus well waiting. That's something going forward will provide some resiliency for our designs. Identify areas in hospitals where we can look at short-term respiratory clinics so that they can be completely separated from patients and other services. In some of the larger rural facilities, identify opportunities to develop or continue segregation of potentially infectious flow in the ED. Sometimes it's really impossible. A couple of my clients have 1 and 2 room emergency departments. They only have 500 patients a year, but when we've got a COVID surge, we've got to deal with trying to separate those folks out. But where possible, if it's larger, think about a separate zone in the ED to make that happen. Bottom line, I think this is the most critical thing, is to keep hospitals, try to keep all of their outpatient services up and running, even while they're still dealing with that surge.
Great. Thank you very much, John. Great to hear what's going on around the rest in those areas where it's so hot right now. Want to go into the scroll down here. There we go. The first session that we have today is hearing on challenges ahead for facilities operations, new modes of operations from the pandemic, and we've asked 5 leaders from around New England to speak to this for about 3 minutes each, 3 to 4 minutes each. So just a quick snapshot from what you're seeing as key issues along this line. George Player from Brigham and Women's, are you able to speak to this first?
Stan, thank you very much. Good morning, everybody. So I'd like to start out and first of all commend all of the facility leaders and the way that they responded to the COVID crisis, the changes they made in their facilities to keep both their staff and their patients safe during the crisis. That's been going on and seems to be continuing. So I think a lot of us are at the mercy of how our buildings were designed in the past, what type of systems we had, what type of equipment was installed, what type of control systems we were operating with. And I think everybody did a remarkable job to provide a real safe environment. A lot of times we were changing airflows. We wanted rooms negative when in original design, they could have been positive. We were even being asked questions about ORs. How could we make changes to ORs, which should be positive? But I do want to talk a little bit about design of our Shapiro Center, which is an inpatient cardiovascular building with about 120 patient rooms and 16 ORs. So that building went live in 2008. So several years prior to that, as we were designing and talking about the facility, the SARS epidemic started in the Far East. And infection control asked us, how could we make a facility negative pressure if that was to come here? And how could we keep our patients and staff safe? We started working with both our design team, who's on the call today, as well as our contractors, and began thinking about that. So we designed our HVAC systems and our control systems to, at the simple flip of a control switch, turn all of our patient rooms, 120 patient rooms, into negative pressure, which we did during COVID. It gave the staff a real satisfaction and feeling of safety. We did a lot of testing, balancing, confirmation that it was working that way. We kept an eye on our air handling units. But we were very fortunate to have thought about that a number of years prior to building the building. And I can remember saying, for 15 years, the building sat there and we never used it. And here was our opportunity. So I will say, never let a good crisis go to waste, right? This is our opportunity to rethink how we design facilities, how we want our systems to operate. And we're fortunate with what we put in. Because not all facilities are like that. Our original bed tower still has some induction units. It's very difficult to even think about changing flow. We are fortunate with one of our kind of mid-age buildings where we have both supply and return boxes. And again, we're able to make changes to airflow to allow those rooms to be negative. So really, Stan, that's the point I wanted to make, is that we did something and thought about something, 18 years ago. We never thought we'd use, and it was instrumental in keeping our facility operational and keeping everyone safe. So thank you.
Great, thank you very much. David Duncan, up at Dartmouth.
Good morning, everybody. Thanks, George. Good updates. Hey, so when I take a look and say what's some of the challenges ahead for facilities operations, there's a lot of them. Boy, the world is different. But I have to start off by, we're in an acute situation right now, filling skilled technicians vacancies. There's a lot of senior people that are retiring, and the knowledge base on running the facilities is going out the door. And it's hard recruiting anybody today. So we really going to need to be thinking outside the box. How do we bring people on, and how do we educate them of the complexities of healthcare and incorporate them into our team? Hey, there's a handful of other big things, and I got some feedback from some of my team, but a big one is that made some sense. I think we need to anticipate similar standards to the ASHRAE water management program. And now there'll be things future about ventilation management programs, including risk assessment, pressurizations, verification, mitigation, etc. So some of the standards that we're already dealing with, I think we're going to be dealing with them more and more. How are we going to deal with some of our older facilities that struggle meeting our air changes per hour? And what do we tell our staff? And do we keep them still operating or not? If that space is going to have potentially COVID positive patients in there, and we have borderline or subpar air changes per hour in some of our older buildings, how are we going to deal with that? Balancing energy management requirements and the added fresh air requirements and the data that's coming on about how important humidity is to keep the spread of COVID down. I think that's going to be hitting us in the future. And then is there going to be some active building monitoring going to come forward that's going to say, do we have high levels of COVID in the air? Is it going to be able to pick it up? Is that some of the stuff that's coming down in the future, and we're going to need to deal with that? And then I think I'll switch again gears to more of our staffing end. We're going to need to do and develop additional better training to keep our facility staff protected. We're sometimes the first people in there, just like the nurses, or we're up dealing with an air handler. We're up opening it up and trying to modify so that we can go negative, etc. And we got to think differently and make sure that our staff are protected. I think another thing that I noticed during the long COVID crisis that we were all working our tail off is the mental and physical health of our staff, the work-life balance. We've completed an engagement survey toward the tail end of COVID. And from a facilities point of view, across the board, the data was coming back. I couldn't let go of work. I went home and I couldn't get it off my mind because of the pressures that we were under. And that struck me as concerning. And it wasn't just leadership; it was staff saying, "I didn't get a mental break of work." And I saw some of the engagement data suffer due to the pressures on that COVID brought forward. And I think that we're all going to have to deal differently with that. And how do we address some of the challenges with engagements, the pressure of the new world has brought to the facilities team, and how can we manage it and keep people engaged, keep people wanting to be here in dealing with our complex facilities.
Great.
So that's some of my thoughts as thinking ahead, Stan.
Oh, thank you very much. You touched on many fascinating areas. And Justin Ferbert, if you were able to make it on the call, would love to get some of your thoughts.
I'm here, Stan. Thank you very much.
Great, thank you.
I obviously I echo a lot of what was just said. I mean, the staffing challenges that we're facing at Newton Wellesley Hospital and really across the larger spectrum of tradesmen is a significant challenge for hospital operations and facilities, in specifically. We've had some open positions at Newton Wellesley Hospital that we simply can't get people to even apply to. It's a very challenging market. Hourly rates are going through the roof, and I think hospitals are behind the curve. So retaining their existing employees is going to be a really high priority because there's a lot of competition out there in the private sector. And I think that's going to be a problem for us moving forward. That's certainly going to be a challenge. As George mentioned, we have some bed capacity issues. I think that's something that we're working on actively at Newton Wellesley Hospital and across Mass General Brigham. Newton Wellesley Hospital is lucky enough to have a shell space. We're looking at fast tracking a design now and incorporating the ability to turn a 24-bed unit into a negative pressure environment for that future state. We're lucky enough to have one of our floors, our 6 East floor, that has that capability, and we utilized it for high acuity patients during COVID, and would continue to do that. So the combination of bed capacity, staffing challenges, staff burnout is a real thing. Again, with open positions being unable to be filled, we've had to lean on contractor labor to offset some of our needs, and that's a cost to the hospital that also becomes challenging. So those things are a primary focus of ours for sure.
Great. Thank you very much, Justin. Wanted to go up to Maine, and Dominic, if you could share some thoughts on what you're seeing there at Maine Medical. If Dominic made it on the call, I checked the list.
If any of you are
There we
really
go. Okay,
interested
there
in
you
coming
go.
to Maine, you're welcome to come anytime you want.
Okay.
No, there's a theme here, and it sounds like my counterparts here are feeling the same thing we are. Staffing is one of our most significant concerns right now. You may have heard recently in the news that Maine Medical Center took a pretty drastic step in compensation to help fill these holes, taking minimum wage from $14 to $17 overnight a couple weeks ago, as well as a 2% hike across the board and other market corrections across another 50, 60 departments. I'm sorry, 50, 60% of the population as well. So it's in hopes of filling a lot of the support roles, trying to keep up with the market rates for housing and so forth in this area. Coastal Maine here has gone through the roof during COVID. I hear from folks that have been here longer than I have that they saw a little bit of this spike during 9/11 as people were exiting some of the city areas, they were buying a lot more properties up here, and it was a little bit of a boom. We are definitely facing that right now. The numbers are absolutely insane, but it's affected our staffing. And then you've got the wear and tear that was noted by several of the folks before me. Sad story, but in talking to a nurse this weekend who works at another hospital, she said there are often days that on her way into work, she wonders if she should turn the car into a tree. And that's on her way into work. They are dreading their daily life and walking into that environment, especially as we see this next peak and things are ramping up again. There was a lot of talk of staff on antidepressants and seeking treatment and so forth, as expressed by this nurse to me this weekend. So it is a real thing. It is going to have a real impact long term. We are seeing it on the trades end as well. Not quite as significant, but what we are seeing is that some of the contractors that we rely on a regular basis, some of which are long-lasting partners that have very close relationships to the hospital, are at a point where they've said, you know what, time out, no overnight work, no weekend work. We just simply cannot get our teams to work anymore. And that is not a COVID thing per se, but we have been in a heavy construction market. We've been in an industry that has just been in this roar for years. And we keep wondering when it's going to downturn. And it's wearing out the staff, and the labor is not quite there. We're not backfilling roles as noted. But more importantly, it's not even about the money anymore. We're hearing that it's just simply burnout. And it's something that we really need to keep in mind. So during COVID, the impact to that is that, you know, we were able to call contractors at any point, have them come in and flip a unit over to negative or do work above the ceiling, whatever needed to be done. It seems like it's always been able to be done. I have concerns that in the future, some of that emergency on-call work will be more challenging, and we're trying to plan accordingly. As far as the physical space goes, you know, things are going well. We've been able to make the adjustments as needed throughout the hospital. All of our new patient rooms that have been built recently or going to be built in the near future are being done with a scale and in mind for various acuities. So ICU level in a med-surg room is possible, and we meet all the guidelines and so forth. That has helped us. So to be able to take an oncology unit, move that population and turn it into an ICU has been incredibly helpful. Visiting in staff areas have been challenging. You know, once you start going to social distancing in those areas, you run out of space quickly. So we've commandeered a number of conference rooms to allow for breaks and lunches. Visitor waiting, even though our visitor policies do restrict the number of visitors, places like the ED, and I know there were comments about care in the ED earlier. Those are areas that are also challenged with visitor space, waiting space, and will be something we'll need to adjust moving forward. With that, I'll leave it there, not to run over too long here on my time. But thank you for having us.
Thank you, Dominic. Great insights. Going to the other end of New England with Mike Smriglio at Stamford Hospital. Mike, if you could join us, and we were talking last week about some of the facilities issues that you're now seeing in that there.
Yep. Good morning, everyone. I feel I'm in excellent company with all that have spoken before me, because I too am facing similar situations, and I thought I was one of the few with the staffing issues. So thank you all for bringing that up. That is challenging. We're all dealing with supply chain issues, and you know, we were at a point where projects were starting up again, and now we're pushing the timeframes out forward because of supply chain issues. No matter how well plans were laid out, we're still facing some long lead items that are given no lead time. But from a facilities perspective, we have a fairly new tower here, patient tower, all private rooms built with a great scale of versatility where the single patient rooms can be double and a PACU can serve as a intensive care unit and so on. Don't want to bore you with those details, but one of the things I was talking to Stan about last week was we were about 3 to 4 weeks ago, we were in a position where we still had our some HEPA filtration units in patient rooms ducted up to the exhaust for negative pressure rooms, not so much as isolation rooms. And we were getting ready to take those out, return the rooms back to normal. And then we started seeing an uptick in our COVID population in the hospital. So we decided to keep the units in place, but really focus on a long-term permanent plan for negative pressure rooms. We have 3 pods on every floor. We can make a pod negative to the adjacent pod, but we need significant work to make rooms negative to the hallways surrounding them. So we are embarking on an engineering study on what it looks like to, 1, make negative pressure rooms, and 2, make more isolation rooms with dedicated exhaust. So I think if we were to plan all over, negative pressure and, well, really isolation rooms would be the key, and ducting them right through permanent isolated exhaust. So we're embarking on a smaller facility master plan. We just have come off one a few years ago, and this is now to look at the vacant space on site, which every month is decreasing due to certain growth in certain areas. So we're looking at what to do with other buildings, but at the same time, we are going to fold this study in as related to COVID into our future planning for the facility. Along with how we conduct, I heard someone on the call talk about planning for the future and how they're going to create even more versatility in the rooms to deal with situations such as this. I don't think this is going anywhere anytime soon. We're with it for a long time, and we're going to adapt and in our facilities planning and our facilities operations. I would be remiss if I didn't plug our team here as well. Everyone is just, everyone in healthcare is just working very hard and very diligently and really caring for each other and the patients. That goes a long way, but at the same time, we do see, as my peers have just discussed, we do see that wearing thin on some individuals.
Thank you very much, Mike. That's
Thank you.
really helpful to hear what you're doing with the change of direction in making some of those changes more permanent, and what you're looking at in your next master plan. I am going to turn this over to Teresa to introduce the next session, and we'll get that started. Then I'll put it back to so the speakers can be seen.
So what we want to do, we're all hearing a consistent theme from everybody. We're trying to look at this from different perspectives of who's the owners, the facilities group, and also the AEC team that can help with what we're hearing during this call, particularly staffing issues and air and energy issues. So what we did was we wanted to take a look at what we're hearing in our design meetings and from clients of what questions are consistently happening. And we divided these into 3 topics. One is balancing energy use with sustainability, changes in patient care locations, and designing departments for flexibility, all themes that we've been talking about. We also looked at a way to frame these discussions with a couple of questions. Are FGI requirements adequate for the specific use? should additional requirements be considered? When should you plan for multifunctional use? And are there technical solutions? And how do I find a balance? So these are things that we're consistently hearing in these meetings and out in with our projects and with clients and ourselves. So that's how we decided to frame our conversation. We had a really good meeting last week and talking about these related to just these things. And as we went through our discussion, that's how those 3 categories on the top came about. I'm going to ask everybody on the team to introduce themselves. We tried to balance the roles of people and also the location. So if you could, I'll say your names, and then if you could just tell everyone your role, your firm, and your location. So Anthony, you want to start?
Sure. My name is Anthony Mistretta. I'm with Perkins & Will, health principal in our firm. I'm a firm-wide resource across the entire firm in our health practice, but I'm based in California.
And can you just talk a little bit about some of your past work?
Yeah, so I'm actually a clinician by trade. I'm a registered nurse and spent most of my career in healthcare operations and facilities, overseeing and running operations as chief operating and chief nursing officer for organizations in San Francisco, such as Dignity Health, and bringing those clinical and strategic operational lenses to our healthcare projects at Perkins & Will.
Great, thank you. Alan Ames?
Good morning, Alan Ames, principal at BR+A Consultant Engineers, mechanical, electrical, plumbing, fire protection engineers, located in 9 cities around the United States, but primarily based in Boston.
Jess?
Good morning. My name is Jessica Stebbins, and I'm with HDR. I'm the principal and healthcare market sector leader for the New England region.
David?
Yes, David Yeager with HED, primarily focused on the national practice in healthcare, but I am a planner by training and practice every day, largely based out of Detroit and Chicago.
John Missouri?
Yep, good morning, John Missouri. I'm the Corporate Director of Real Estate and Development at Mass General Brigham in Boston.
And Andrew?
Good morning, I'm Andrew Zimmer. I'm with HGA Architects and Engineers. I'm on the architecture side of that. I'm a healthcare principal. Like Tony and many others, I get to work around the country, but I am based out of our Milwaukee office. My work recently, which we'll talk about today, some of the examples we're hearing has been around the Midwest and the Mid-Atlantic and the Southeast. So I'll share some of those perspectives today.
Great. So we're going to start with Ellen and David and talking about balancing energy use with sustainability. And David, I want to start with you. I know you have some topics that you like to start with your clients, and maybe you could talk us through that and relate it to kind of the way to frame the responses that we talked about earlier this last week.
Yeah, sure. A lot of others have talked about all the challenges, particularly the directors of facilities. So we clearly understand that. Working with our engineering partners, some of which are certainly on this call today, with the exception of patient care units, we've come up with a list of priorities in terms of responses. And I'll just highlight those. There's 6 of them all together. The first, and this is in order of general priority with our clients, distributing and returning air properly. And I would say that in congregate areas, particularly waiting rooms, and let's not all forget that corridors are congregate areas. They have a lot of activity in them. So distributing air properly is an important thing. And again, I'm an architect, not an engineer. So, but these are certainly things that we have to work with our engineering partners to work through. The second is filtration, largely HEPA filtering and others. Number 3 is humidification. I think we all learned through particularly COVID how important humidification is and to get it right. Typically the higher level of humidification is better for limiting infection. UV lighting, UV lighting and bipolar ionization in the ductwork or in the HVAC system. And lastly, with one big caveat is that 100% outdoor air, no reuse, all exhausted units would be number 6 on the list, except for patient care units, which would obviously go toward the top. I know others talked about switching systems, being able to adapt patient care units into all exhaust units. Certainly agree with all that. So in terms of that sort of intervention approach with our clients, that's what we've been recommending for either renovation or new construction, to take a very proactive approach to understanding this. And I thank all of our colleagues on the phone here today, all the mechanical engineers in particular that have really done a great job over the last, well, even since SARS really, but over the last couple of years, trying to make sure that all the vendors are helping us meet the need. And then did you want me to talk about some case study, Teresa, now?
Well, I think let's go through with everybody first, and then maybe we can jump back to that.
Okay, real good.
That's really great. I think that list is really valuable for people to understand. And Ellen, if you could talk a little bit about what you've been doing, and I know you mentioned airflow and additional capacity and designing for emergencies, or maybe converting spaces to emergency use.
Sure. I'm just going to share my screen with something if I can. How do I do that? If I hit share screen, that'll work.
There should be a green share screen button there.
Yeah.
At the bottom.
Hold on a second.
If you move your cursor, it'll probably show up.
Yeah, unfortunately, it's not doing it. Anyways, so FGI issued on March of 2021 the guidance for designing health and residential care facilities that respond and adapt to emergency conditions. I was going to just share the cover sheet from that. So as part of our discussions with healthcare facilities, obviously this is at the top of everyone's list, is trying to figure out what they need to do, what they want to do, and not only for existing facilities but for new facilities. We were looking at not only inpatient facilities but outpatient facilities, and how they might approach those facilities, because you have a steady stream of patients coming into those facilities, and you want to protect everybody in there. And then the balancing of the energy side of it, as David mentioned, that when you go to a 100% outside air system and go to negative airflow in the building, it affects the energy performance, which goes against the operational bottom line of any facility. So a lot of the facilities are looking at the ability to change it. George mentioned that earlier, is that if you design it so that it can be in a recirculating mode, but then have the capacity in the chill water system, in the heating system, in the air side systems, to be able to flip it and to be able to increase the airflow in specific areas is another thing that we're seeing a lot of. A couple facilities in New England that we've been working on, we're looking at the ability to go to 100% outside air and then make them negative pressure for those facilities. So as a result of that, we increased the basically had to change out the air handling equipment to accommodate that. We're looking at putting, as David mentioned, needlepoint ionization in those recirculating units in the interim conditions, so that they don't have to use 100% outside air. And overall, trying to make the rooms adaptable. Another part to the making them adaptable is making sure that the head walls in the rooms have the ability to adapt to basically an ICU ready head wall. And and then finally, on the outpatient facility side of things, we were looking at how, when people circulate through the front door, it's not an emergency department, but they're coming in and they're potentially COVID positive, and how you treat those areas, plus the waiting rooms and exam rooms where they might be going, like respiratory areas and things like that. So that's all part of the overall discussion and where we're going with the current design.
Great. I'm going to now ask Jess and John to talk about changes in patient care locations. And Jess, I think what Ellen was saying of, you're on mute, of multifunctional space, universal rooms, if you want to just jump in and start discussing that.
Yeah,
with us.
sure. Happy to. So I'm going to talk about like 3 points. One, trends we were seeing pre-pandemic, what we learned during the pandemic, and how the pandemic is changing the model of care in ambulatory. So pre-pandemic, we were seeing a lot of the larger AMCs moving towards universal rooms for their capital investment projects, large projects, right? And so we would be designing to an ICU level. This allows for flexibility to shift between med surge, ICU, and step down with minimal, augmentation to the room or to the infrastructure of systems. This really allows, modalities to grow and shift with little disruption to overall operations, and that a movement more towards on stage and off stage of patient flow and services is pretty key in the designing of these facilities. When we were in the midst of the pandemic last year, we were wrapping up the new patient care tower at Dartmouth Hitchcock Medical Center. And prior to issuing the drawings, they asked us to do a peer review of the drawings to take some of the lessons learned regarding separation of flows, as well as looking at air flows. What do we need to make the new facility more pandemic proof? One of the takeaways that we learned from the project was to add operable windows as a passive survivability strategy. So one, we can provide natural ventilation if needed, but at the same time have a place for exhaust units to be located. What's unique about the Dartmouth Patient Care Tower is that it does not sit on top of a D&T block. So it really allows the unit to be segregated from the remaining patient population. And again, I think, taking analysis and looking where, proper donning and doffing can occur in the overall flow of a patient unit is also important. Kind of where we are in the current state, and I'm sure I'd love to hear from my colleagues out there, but I would say back in March, we've seen a significant number of master planning activities that are going along the entire East Coast. AMCs are focused on consolidation now, termination of leases, strategically positioning the ambulatory care facilities on campus, really looking to maintain non-clinical functions at home, so remote work, and converting administrative spaces more into diagnostic and treatment areas. Again, this movement of removing the ambulatory programs out into the community is pretty, is where we're seeing the market going right now. One thing we learned during the pandemic is the use of technology and how to leverage that to communicate with our patients, either through virtual visits, more of this telehealth activity, so there can be more remote monitoring of the patients at home using devices or wearables, and how this is impacting kind of the physical environment on ambulatory care is that we're seeing more of a movement of pre-registration, check-in in the rooms, wayfinding through an app. We're also looking at more flexible rooms for consultation for virtual visits or teleconsultations with other specialists within the entire network. And these concepts of clinical hubs, right, that monitor the data that comes in from the patients, analyze it, and to be able to respond to the patient, right? Whether it's deploying emergency assets, phoning in a prescription, or just calling the patient to give them some advice. So this movement of moving patients more in the home is the direction that we're seeing. And I'm going to pass. Oh, go ahead.
So John, I think that's a great segue into what you could maybe share with us in terms of the percentage or the flow of patients across the system.
It is, and thanks, Jess, for setting me up in a good way. What we're spending a good bit of time doing inside MGB, Mass General Brigham, these days is analyzing our inpatient populations in particular, and trying to put patients in the most appropriate level of care. And in many instances, that means trying to direct them to a community hospital rather than one of our downtown AMCs. I think that's obvious for obvious reasons for everybody on this call, but you know, it's not easy. And the opposite end of the AMC, downtown AMC hospital, is a program that we're seeing a lot of interest in, and that has grown dramatically recently, and that is our hospital at home program. We have about 3,500 beds, inpatient beds across our system. We have more than 3,500 patients on any given day in our hospital at home program. So that just it's taken off dramatically through the COVID period, again, for obvious reasons. It's a program that began at Spalding Rehab Hospital, primarily with patients that were going through long rehabilitation after, recovering from traumatic brain injury or stroke, cardiac rehab, things like that. And it's found its way into our downtown hospitals. Typically, the hospital at home patient is discharged directly out of the ED. They don't even get into an inpatient bed at the AMCs, and it's patients who are eligible for an inpatient bed, but who are willing to receive their treatment at home. And so those are patients that are primarily suffering from chronic illnesses, COPD, asthma, bone healing. They are seen in the emergency department by somebody who we call an alternative pathway navigator. I could use one of those most days too. But they're typically a nurse practitioner, and they're trained to clinically review the patient for suitability for entering the program. And if they are determined to be suitable, then there's a consultation with the patient and the family of the patient. And if everybody's in agreement, then we send them home. The way the program operates is that a nurse will visit them 2 times a day at their home. In the first 24 hours, a supervising physician will also either visit them directly or virtually, depending on the circumstances. And a nurse practitioner will stay with them also, or rather visit them also, for the duration of their time in the program. As I mentioned, we're seeing typically older patients with chronic conditions are the patients who are entering the program out of the AMCs. Congestive heart failure, cellulitis, pneumonia, urinary tract infections. We have allied with that group is a group that's called, they're called the Healthcare Transformation Lab. And they're really working on the technology aspects of this. And it really has to do with what technology is the most reliable, what technology is the most comfortable for the patient, what technology is the most accurate at transmitting vital signs. Is it a patch on the chest, an armband, a wristwatch? How often should the monitoring occur? That's obviously dependent on the patient's condition. And what are the best tools for monitoring, some of the basic vital signs: heart rate, blood pressure, oxygen saturation, and then how do we effectively transmit that information from the home back to the team that's overseeing the care of that patient. So, these programs are obviously very dependent on technology to operate, and for not only for monitoring, but also for reasons of safety. We are finding the benefits of this to be at least 2 major benefits. One is it's easing ED overcrowding. Because we are able to peel off patients who are appropriately put in the home care, the hospital at home program, then obviously they're not waiting in corridors and other places for a bed upstairs, and like everybody else, we're full. It's also obviously reducing the patient's exposure to hospital-acquired diseases and delirium, which is a problem with our older patients. And it's also providing us an opportunity in the home environment to monitor what the social situation for the patient is, especially again, if it's an elderly patient, do they have the support systems in place already? What are their meals? Are they eating wholesome meals? Are the family interactions healthy? All those kinds of things. So it really serves a number of different functions that at the end of the day are all about the health, well-being, and safety of the patient. So I'll end there.
Thanks, John. And that's a great lead into Anthony and Andrew's topic, which is designing departments for flexibility. And I know, Anthony, you talked about ED zoning and staff respite, and also the staff comfort with technology now that may change things. And how you're on mute.
Thank you. Yes. So yeah, quick. I can talk fast, being an East Coaster, and one of the big things, like some of you guys know, not to repeat what a lot of my partners have said, but as we talk about and think about the ED and other parts of the DNT, we had many clients across the country who wanted us to do a retrospective analysis of plans that were either in DD or even CD, to take some best practices and lessons learned from COVID to see how we may alter the environment before the built structure is actually in place. And overwhelmingly, we had at least 4 clients who we've revisited their ED and thought about things differently. And I think the key is to help our clients not really go too far to the extreme to build and alter the environment operationally to function in just the COVID world, but how we do this balance and put these minimal interventions in place to allow for the department to flow and operate in a normal, whatever normal is anymore these days, flow when we're not in an emergent or pandemic state, but able for the environment to flex to be able to provide a different flow, segregation of flow within the environment, whether it's just adding a couple sets of doors to offset some flow, breaking the ED into different segments. So when we have an infectious outbreak, whether it's a pandemic or it's a horrible seasonal flu in a region, that they can adapt and take these best practices that we've learned. For so long, we've just taken the flu as the flu in healthcare and probably could have done a better job of separating this. So how do we take these and actually apply them to the future of these environments without doing major modifications that inhibits the regular flow and the day-to-day operation of the environment? And on that, like, a big piece that's come to light, and I think you heard it through all of the facilities directors and all the different representations of clients today, we're all struggling with this concept of staff retention, staff burnout. These are real things that are not going away. And as design professionals and as a former owner myself, we've not given the value to the spaces of staff respite that is needed. And I'm talking beyond just a break room and places for relief and turning conference rooms into break areas to allow for social distancing. These are important concepts we're dealing with today, but really being able to provide, as design professionals, working with our teams to understand how we can bring true areas of respite into the care environment. These are people who are not returning to work and have never had a break. And the poor example of a woman who wanted to think about going into a tree. During the 8 or 12-hour shift, there's nowhere for these people to really just process what's happened, either alone or with fellow team members. And it's an overwhelming issue that we continue to hear about. So how do we make areas for our staff? And they're not the spaces that are VE'd out the first round of VE, because we can make the room smaller and kind of put people into the similar environment. And last but not least,
sorry, go ahead.
That's okay. I was just going to say the topic of the technology John was so much talking about too, what's been able to allow us is this remote monitoring, concepts that nurses and clinicians have never been really willing to actually take into consideration. Now COVID has taught us that I can monitor ICU patients and other patients from outside the room and not necessarily have to go in to do an intervention every single time, and how much more can actually be done from an external environment in a centralized way. It'll help with our staffing concerns and issues the more comfortable we come with it. But the key is that clinicians are willing to sit and talk about these today, where we haven't even just a year ago.
That's great. And I think, you know, exactly what you're saying, spaces that used to be vulnerable during programming, like staff respite or staff lockers or even storage closets, we have to rethink that priority. And Andrew, I'm going to turn it over to you now to talk a little bit about, you know, you mentioned larger clinical spaces in ambulatory and also accommodations for different populations are very important.
Will do, and I will be East Coast as well, Tony, and try to cut these quickly. But boy, I wish I could learn more from the other panelists. Really interesting stuff. Wish I had more time for the rest of that. So a couple things on the ambulatory side. It used to be that rooms were getting smaller and smaller as we tried to lean things out. Now they're getting kind of bigger and bigger again. So on the exam room side, what we're seeing is it used to be 110 square feet, maybe even squeezing that further. We're seeing that to be more like 130, 140 now. And that's driven partly by specialties like orthopedics that need those larger clearances for wheelchairs, things like that, or oncology, where you have the large family gatherings to provide that support. But it's also getting more flexible. Just mentioned the ambulatory planning and the flexibility of that to do any service line in any space. So we're seeing these examiners get a little bigger to be more flexible. In the same way that we're seeing ambulatory surgery move from hospitals to ASCs, in the same way clinics are seeing more procedures, I think kind of slowly migrating to the clinic settings. We're seeing more procedure rooms. Used to be maybe 1 to 12, now one procedure room for every 12 examiners. We're seeing more like 1 to 6 or 1 to 8 now, as those are migrating more to that setting, which is another interesting thing that drives square footage up. Then on the collaboration side and telehealth, we've mentioned this already, but we're seeing the private office is not coming back. But what is coming back is maybe more of these small kind of heads down hoteling spaces in those staff collaboration zones. So providers can either do heads down work or increasingly do telehealth consults. We're seeing a lot more of that. And then the rest of that space is more modular, not so much built-in casework, a lot of modular furniture, so you can compress or decompress based on the demands of that particular clinic or say a COVID transmission risk, things like that. And then one last note I would like to make, if I may, Teresa, if I have one more minute.
Yep, exactly.
Another interesting trend is that there's a lot more sensitivity now than there was to different kinds of patient populations. So it's not just about clinical needs, it's about the non-clinical needs of the human beings walking into the door. Things like, am I able to mentally or emotionally handle what it's like to be in that waiting room, whether I'm afraid of getting COVID or just anxious about whatever in my life. So providing space for people like that. Or people who have physical disabilities or special needs. I heard a patient tell me recently, their father said, my son comes in, he isn't always under control and he scares the other patients. Can we provide some separate spaces, whether they're private rooms or just private areas, carved out of waiting spaces to provide that, to make everyone more comfortable. Really important, not just from infection prevention, but from a human and wellness perspective. So that's another trend I think we're going to continue to see in ambulatory environments.
Great. Thank you, everybody. This has been a really good discussion. I appreciate all the time that you've put into thinking about this and sharing it.
Great.
And I think we're at time now.
Yes, thank you again. We will be able to circulate the video in about a week's time or so. Just wanted to, so that will be sent around. A lot of great ideas and thoughts shared. Richard, would you like to do a 30-second wrap up on for the discussion?
Sure. Well, thank you, Stan and Teresa, once again for leading a wonderful conversation, and most of all to our panelists. Just so informative. The whole idea is sharing our experiences for the betterment of our population, and you've done a great job. I know we've all taken a lot away with this, and we look forward to our next meeting. Thank you, everybody.